To start us off, could you give us a bit of your background? You're not our typical
Mm-hmm.
guest on
Yes.
Contagion. You're not from the infectious disease space, but we do that sometimes. So give me a
Mm-hmm.
little history.
Okay, so I am a medical speech language pathologist. I'm currently the outpatient adult lead at the University of Mississippi Medical Center and the co-chair of Dysphagia Research Society's International COVID-19 Task Force. So I know for a lot of people listening, they're not always familiar with all that a speech therapist or a speech pathologist does, is because of the way our profession is labeled, where the first thing that comes to mind is speech. But as medical speech pathologists, our bread and butter is fixing people's swallowing issues. So even aside from COVID, we go in with patients with critical illnesses, stroke, brain injuries, head and neck cancer, and help improve their swallow function, help them eat and drink again. And then we also help patients with their speech, their language, their communication, and with cognitive impairments. So across the continuum of care, we have speech pathologists who specialize in these issues in pediatrics, in adults, and then some who work in nursing homes and do the same with geriatrics.
And can you give me a bit of your day to day before the pandemic, and then we can have a bit of contrast?
Yeah. So I've really worked across the continuum of care. Started out in acute care, worked in the nursing home, and currently at UMMC, I'm at in the outpatient setting. So in an outpatient setting, me and an ENT, we have clinics together, and then I have my own clinic where patients are walkie-talkie, they're outpatients. So they're coming in because they had some kind of injury that led them to live in the hospital for a few days, and then they need post-acute rehabilitation. So, 8 to 5, I'm in my office, I have patients walk in, we do 60-minute sessions of whatever it is they have an impairment with. So either swallowing, cognition, language, speech. And that's kind of what my day to day looked like. And then when I had joint clinics with the ENT or the otolaryngologist, we scope patients, watch their vocal folds, see if they need further instrumental assessments to assess their swallowing. So a lot of assessment and mostly outpatient therapy.
And how has your average patient profile changed since the pandemic started? Are you seeing a lot of COVID related post care complications, things of that nature?
hmm So I also work in acute care. So I think the biggest change outpatient wise across professions was really like in the first few months, I would say, or weeks, people didn't know what COVID was. So obviously our caseloads took a hit. I know clinics across the country that just closed down completely because we wanted to limit the footprint. We wanted to limit how many patients are coming in. So my initial 2 months in outpatient just meant hardly seeing any patients. All elective procedures were canceled. We weren't scoping patients and we weren't doing those instrumental assessments that generate any kind of aerosols. So when you're working with swallowing and voice, a lot of what you do is getting those particles out in the air. And those are called aerosol generating procedures, which we know are more likely to spread COVID-19. So we kind of weren't doing any of that initially. And in the acute setting, there were only so many patients we could use PPE and go in and see, because really when you had that shortage initially across the country, the ICU physicians, the nurses, the surgeons, they were like the most essential staff, right? And then we tried to do the best we could for every patient. So I know UMMC never had a shortage, we could still go in and see patients, but we just couldn't see them with the kind of frequency we like to see them in acute care, which definitely impacted the rate of recovery and their overall outcomes.
Well, that's of serious interest. And
Mm-hmm.
are you also seeing ventilator associated need for recovery that's related to COVID? Because I think that actually brings up a division here.
Mm-hmm.
We can talk about how has COVID or what are the speech language pathology needs of people who are impacted by COVID-19, and then
Mm-hmm.
how has COVID-19 response impacted people who had prior speech language pathology needs? And I think you've already drawn that out a bit there.
That's a great question. Because typically COVID-19 is a virus, right? But what's interesting about this virus is initially they thought, oh, the older people who are more frail and they have coexisting conditions and comorbidities, they're the ones going on ventilators. We're seeing younger people now who may not have um, a pre-existing illness who could develop what we call ARDS, or acute respiratory distress syndrome to the point where they just can't breathe on their own. They end up needing mechanical ventilation. So they're a little bit different from the typical patients we were seeing who needed those tracheostomy tubes and ventilation, because they have an underlying respiratory illness which is causing inflammation. In a lot of these patients, we're seeing, they need anywhere between 2 to 14 days of dependence on the ventilator, sometimes even longer. So I think the biggest issue is, imagine you walk in and you wake up and you can't breathe, you can't eat, you can't speak, and you're isolated because you don't have your family in front of you because of the infectious nature of the disease. So really, speech pathologists come in right there, because we help patients use something called AAC, augmentative and alternative communication devices, to help them communicate their wants and needs while they're on the ventilator. When they're off the ventilator, they have muscle disuse, their vocal cords might be damaged because of the prolonged intubation, and most importantly, they can't swallow. So their rehab needs start right there. And depending on whether, how deconditioned they are, what kind of swallow respiratory incoordination they have, my job is to get this patient to start eating and swallowing as soon as possible and minimize the risk of what we call dysphagia, or a swallowing disorder. Because if they end up choking or aspirating, if something goes down into their lungs while they've just recovered from COVID and their baseline respiratory system is already damaged or weak, they can get pneumonia again, which is going to end up extending the ICU stay, can lead to other complications. So really helping them with get their voice back, helping them with their swallowing. And if they have neurological impairments, we're seeing that in patients now. We're seeing memory loss, attention deficits, issues with just doing basic activities of daily living because of that extended ICU delirium. We help with those cognitive impairments and getting those back to baseline again as well.
And so when it comes to that recovery period, you highlighted a lot
Mm-hmm.
of the physical effects. The delirium is of interest because that
Mm-hmm.
sort of lies at an intersection between the psychological, neurological, and kind of emotional, physical response. Are you seeing that people who you're working with to try and help recover from COVID-19, what's their emotional state like? I mean, it's in people who get severe infections, it's a very nasty experience.
It's horrible to begin with anyway, like I said, right? If you are in that situation where you're just surrounded by like drains and tubes and you have a tube down your throat, you can't breathe and speak and eat, it's a frightening situation to begin with. And then they're also medicating these patients, which can cause like hallucinations, more delirium, confusion, and just, I think, just having people around you with masks, barely able to make eye contact and even watch what they're trying to say, not being able to reach your family. So I think the psychosocial impact of that is just tremendous. And the papers I'm reading, I guess we don't know enough about post COVID data, which people are still analyzing a lot of hospital data. But I know the most recent paper I read is that up to 40% of these patients are seeing prolonged neurological deficits. So who knows? Like that might go away in a few weeks, but if you already had a stroke or COPD, or like an older person with early onset dementia to begin with, like who knows how long that's going to last.